Um, on behalf of Chelsea Cipriano, who serves as the managing director of the coalition, as well as our founding members who are listed here: AHIP, the American Medical Association, Kaiser Permanente, ACHP, and the American Hospital Association. I've scanned the folks who have already joined the webinar, and it's really wonderful to see so many representatives from our coalition members. This is, the forum that we hope to be able to forge, to be able to exchange ideas, lessons, and ultimately take some action together. And for anyone who is not yet a coalition member, I hope you'll be inspired by our wonderful presenters today and think about joining the coalition, about which you can learn more at commonhealthcoalition.org. Next slide. Okay, first, a little bit of housekeeping. We really aim to make these events as interactive and engaging as possible. So I encourage you to please, pick up your mobile device or just another tab on your computer. Go to slido.com and enter in this number. Or if you're on your mobile device, just scan this QR code, and that will get you loaded up for some of our interactive activities. So I'll just pause here to give folks a moment to do that. And then we can move to the next slide. A little bit more about the mission of the Common Health Coalition, which is fundamentally about strengthening partnership between healthcare and public health. We like to think about this as a common goal, which is health, regardless of which sector you're primarily involved in. We all ultimately aim to improve the health of the people whom we serve. But too often, we don't do this through strong collaboration, through building bridges and dissolving silos. And so that's what we are aiming to advance through the coalition. We think about this as an uncommon approach that we can make more common with time. So our purpose is written here. We consider ourselves focused not just on crises such as pandemics, but also all of the slower moving disasters, whether it is maternal mortality or the overdose crisis or chronic diseases, which we know cause undue suffering and the loss of our loved ones too often. And so we aim to strengthen collaboration between healthcare and public health and translate particularly the lessons learned from the COVID-19 pandemic into lessons mobilized for action. And you'll hear a lot more about how concretely organizations around the country are already doing this in the event today. Next slide. We have 4 focus areas for the coalition's work. I won't go through all of these, but we use the acronym CARE to describe these 4 areas. Everything from the exchange of data or real-time disease detection, emergency preparedness. But the C in CARE is what I really want to highlight because it is the element that we're aiming to lift up in the conversation today. The C denotes coordination between healthcare and public health with clearly delineated goals, roles, and responsibilities. So often this takes the form of relationships that so many of you already have. People picking up the phone from a healthcare system to someone they may know at a public health department, and figuring out ways to work on common problems together. But we also want to move this into more of a systems-oriented approach so that we think about data sharing agreements, memoranda of understanding, and other ways of formalizing this coordination, particularly before we have to do it in a time of more urgent crisis. Next slide. So you've heard enough from me. What I want to do is to please invite you to talk about one word that comes to mind when you think about what drives strong collaboration between healthcare and public health. It looks like we have some starters here, and maybe folks can just add via the slido.com poll. All right, thanks everyone. I know folks may still be typing a little bit. What I see is that, some of the elements that have risen to the top here, communication and trust, which were part of the starter set, certainly underscored in terms of what people think is important. But I also saw relationships and respect, and I really think about, sort of the way in which those things are tied together, to forge, trust, and ultimately to drive the collaboration that we're seeking to bring forward. So thank you so much. All right. Well, this was a nice warm up for us to think further about how to make some of these ideals real. Without further ado, we'll go to the next slide. And it's really just a privilege to get to introduce our moderator for the afternoon, John Auerbach. John is a friend, a colleague, has been a mentor and an inspiration for so many of us who care deeply about these issues. We'll put his full bio in the chat. It is a very distinguished, set of accomplishments over the course of his career, but I'll just briefly try to encapsulate them. John currently serves as Senior Vice President at ICF and is therefore their primary federal health expert within the company's public sector business. Before that, he was at the CDC, where he served as the Director of Intergovernmental and Strategic Affairs. He and I got to work together during the COVID-19 pandemic, and I'm so grateful for his leadership on the CDC Health Equity Work Group and serving as the Chief Equity Officer of the CDC's COVID-19 response. He's one of these people who has moved seamlessly between worlds. He was the president and CEO of Trust for America's Health, which many of you will know well, as well as the former public health commissioner for the Massachusetts Department of Public Health. His list of laurels is too long to go through, but he was the APHA Excellence in Public Health awardee, and is a prolific author and someone who is always on the cutting edge of thinking how we can do better in terms of advancing health. So with that, John, I'm really grateful to you for being willing to moderate this conversation among our esteemed colleagues, and I'll turn it over to you. Thank you.
Oh, well, thank you very much, Dave, and I really appreciate that kind introduction. And most importantly, thank you for your leadership in founding and guiding the Common Health Coalition in its first year. You and its members have really accomplished a lot in that year, bringing together key organization representatives from both the healthcare and the public health sectors. And as someone who has been involved in policy and practices for decades at the local, state, and federal governmental levels, and now in the private sector at ICF, I really appreciate just how important it is to strengthen our coordination and collaboration. And that's always been true, but COVID really taught us about the urgency of the task. And now, as we enter a period of dramatic change, it's crucial that we engage in joint conversation and practices as much as possible. Since the election, we've already heard a number of dramatic health-related proposals, and we'll likely see significant changes in federal health policy and funding in the coming weeks and months. Members of the healthcare sector and members of the public health sector will certainly want to weigh in on these proposals and policies, and will be more well-informed and effective if we can do so together. And that's what the coalition is all about. To discuss this topic and other related ones, we're incredibly fortunate today to be joined by an outstanding panel of leaders. They are Dr. Dora Ann Mills, who's MaineHealth's Chief Health Improvement Officer, Dr. Frederick Chen, who's the American Medical Association's Chief Health and Science Officer, and Dr. Rishi Manchanda, who's the CEO at HealthBegins. Since this webinar is kind of a fireside chat, I hope that each of you don't mind if I call you by your first names, though, as we begin to have the discussion. Before beginning to hear, though, from our panelists, let me remind those who are watching to list in the chat section of your screen those questions that arise for you during the discussion, and then we'll have a period of time when we'll be taking your questions. So with that in mind, let's jump directly into it. I'd like to begin by having each of you briefly introduce yourself and where you work, and then share a key example of how your organization has fostered strong and sustainable partnerships between public health and healthcare systems. And maybe as part of that, you could also share some of the key factors that contributed to the success of this partnership. And Dora, why don't we start with you?
Sure. Thank
Delighted
you.
that you're here.
Thank you, John. And I'm coming to you from MaineHealth in Portland, Maine. You can see some photos from Maine behind me. And anyway, thank you so much. I want to particularly thank Dave and Chelsea for their 1-year anniversary. I think this Common Health Coalition is a fabulous idea. Having served as the state health officer for Maine for nearly 15 years and having also a career in healthcare, I feel like I've had my foot in both fields for a long time, and it's just wonderful to have an organization that can help bridge those two fields. At MaineHealth, we have been doing this for a few years, so that's why we are excited about this support and collaboration and just learning from others that the Common Health Coalition will bring to the table. So we are a 10-hospital healthcare system serving most of the most rural state in the country with all of our community hospitals in rural areas. Now, one of the reasons why we've developed the infrastructure I'm going to describe is because rural areas face a triple challenge in this country. Number one, we have poor health status in rural areas. The disparities are tremendous. People in rural areas of this country have much poorer health status than urban areas and certainly suburban areas. Number two, we have overstretched healthcare systems in that we have much worse healthcare workforce shortages in rural areas, along with increased demand because of aging populations and poor health status. And number three, we have a very sparse public health capacity in rural areas across this country. In fact, in all of New England, there are no rurally located accredited local health departments. So we in rural areas of New England, and this is true across a lot of the country, rural areas, is that we're served by the state's public health agency, which do a fabulous job, particularly with the regulatory functions that they must provide. But the non-regulatory functions, often they're just too stretched too thinly. So at MaineHealth, our headquarters and our flagship hospital are here in Portland. And what we've done is we've created a hub and spokes model to provide a more robust public health services across our service area. And it's very much in partnership. So for instance, our spokes are our local community health departments in each of our community hospital service areas, consisting of a community health director and other public health professionals who oversee local partnerships with primary care physicians, local government agencies, and community-based organizations or CBOs. Our centralized hub has resources such as a grants office, health data and analytics, program evaluation, system-wide and statewide programs. Many of the centralized resources count toward our IRS required community benefits. We have about 300 staff at the Center for Health Improvement, which is this hub and spokes, CHI. And we actually this last fiscal year, we had about $16 million in MaineHealth operational funding, but $19 million in external funds, mostly governmental public health grants, federal and state. And about 1 in 6 of those dollars were put out to CBOs, community-based organizations. So that's kind of describes our infrastructure. And again, very much a partnership at the local level with CBOs, clinicians, and local governments, municipal and all that, county governments. But then at this hub level, we also are very much in partnership with their state public health agency and statewide organizations.
Thanks so much, Dora, for that. Let me now turn things over to Rishi. Rishi, please tell us about the work that you're doing and the impact that it's had.
John, thank you so much. It's a privilege to be with you, with Dora and Frederick, and also with everybody at the Common Health Coalition, including Dave and Chelsea. First, let me say that we are huge fans, as Dora mentioned as well, of the Common Health Coalition. Happy anniversary. The work is just beginning to help bridge the long divide that has existed between healthcare and public health in service of, I think, a shared goal of improving health for all. It's incredibly exciting and I think incredibly relevant now more than ever, especially as we consider what's coming in proposed policies at the federal and state level with the incoming administration. HealthBegins is an organization I founded 12 years ago and has in the last 7 years been my full-time work. And what we have been doing is to understand a few things as a national mission-driven consulting and training firm. And I'll use this to use that framing to orient to answering your question really quickly, John, about what it means for healthcare and public health. So from our perspective, our core mission at HealthBegins is to drive nothing short of radical transformation for health equity. What does that mean? First, we recognize that inequities, whether it's healthcare inequities, what we see in the healthcare system, or more broadly health inequities that we see in the community or in the public, are experienced as harm. The second core observation is that it is, in fact, social and structural arrangements and practices, economic, political, and social, that put people in harm's way. And so to move upstream, as we describe it, to be an upstreamist, is to mitigate, confront, and transform those unjust social, economic, and political arrangements that put people, some more than others, in harm's way. As a critical part of that work, how we actually then achieve that mission is the work of bringing together folks in the shared garden, all trying to cultivate health. Really bring the gardeners in the healthcare system, the gardeners in the social sector, community-based organizations in particular, to be better at not only achieving their own missions within their own sectors, but then to be part of the broader kind of working with governmental public health and broader non-governmental public health efforts as well. So what does that mean as an example? We work closely with Medicaid managed care plans, health plans more broadly with Medicare and commercial lines of business, with health systems, and fundamentally with social sector partners, those gardeners and those other spaces. And by engaging with them to achieve their health equity, healthcare equity, and social needs performance measures and goals, we apply a multi-level kind of plan of action to say, now, how can you not just improve care in your clinics or in your CBOs in your organization? How can we actually make sure we're aligning to create partnerships that then align with broader public health goals at a system, an ecosystem, and even more broadly? Let me give you one concrete example, John, and then I'll pause here, of what this looks like to effectuate, to mobilize healthcare and community-based organizations to be part of the broader public health agenda and to coordinate with public health departments. In 2021, we were engaged by a large health plan in California serving millions of members in the Medicaid space. We were engaged by them to help accelerate their vaccination response, to ensure especially that those most vulnerable were getting access to COVID vaccines. And what we did after designing a campaign that brought in community-based organizations as a necessary part of the solution was to, within a 4-month campaign, reach over 1 million people through targeted community outreach, aligning the health plan's interests, the community's interests, and the public health interests. Administered 30,000 vaccines just by 10 CBOs, helping to kind of do work, and reached through the social messaging and marketing kind of work more than 1.3 million people per week in targeted messaging. There are gardeners in the broader kind of space that we occupy right now who are aligned with and can be better activated to be part of the public health mission right now and to help partner with governmental public health agencies and non-governmental public health work to be able to be part of the broader enterprise here. And those include healthcare and social service kind of partners. Our role here is to think about how we can help serve their needs, but also mobilize them to be part of the broader public health agenda.
That's great. Thanks so much for sharing that. And Freddie, let me turn things over to you. We'd love to hear about your work and how it's fostered partnerships as well.
Great, thanks, John. I'm Dr. Freddie Chen. I'm the Chief Health and Science Officer for the American Medical Association. I'm a family doctor, but in this role, I oversee our public health, science, and actually ethics work for the AMA. I think it's worth reminding sort of folks that public health is actually part of the origin story for the AMA. It's very much part of the history of this organization, growing up through the public health and hygiene movement. It is a key part of our mission statement, which is to foster the art and science of medicine as well as the betterment of public health. I think we've heard these important sort of stories at the state level and also at the healthcare system and delivery level. I would just talk a little bit about sort of how important our national sort of and federal relationships are, and how AMA helps contribute to this in this way. We're close partners, obviously, with the CDC in the through the depths of the pandemic, sort of coming out of that and recognizing the needs for a better public health workforce and better public health infrastructure, helping to get the word out to practicing physicians sort of through our federation of medical societies, organizations, and state associations. And I would also just highlight right now, a lot of the work is at the level of helping to engage individual physicians, many of whom are working in large health systems, around really, really key public health topics. So obviously the infectious disease piece of it, but now issues like firearm violence prevention, climate change, reproductive rights. These are all areas where physicians in health systems, in hospitals, really want to take some leadership roles and are important voices in that and in engaging with the public health community on that. And we feel we find part of our role is helping to educate and enable that to happen. We really, really value our sort of federal relationships with our public health agencies, and obviously sort of working closely with them, especially as we go into this transition period. So really excited to be here, really important voice. The sort of healthcare and public health interface continues to be a real driving part of our mission work.
Well, thanks to the three of you. It's clear you're doing really model work at bringing together the members of both of the different sectors, and also being very sensitive to community members and patients through that process as well. Maybe I'll throw out a question that you can talk among yourselves about, or one at a time, or engage in it as a group, and that is, if you could give a concrete approach to a step you would take for improving better coordination. And maybe the hypothetical would be, let's say that there is a significant reduction in, say, Medicaid or reimbursement, and there's a significant reduction in some public health funding that's going to affect your communities, and you're reading about that or you're hearing about that. Are there steps you would take to ensure that there were discussions that were taking place with people from both the healthcare side and the public health side about the nature of those cuts, what they might mean, and how you might respond? Because again, it's hypothetical, but you probably have situations where COVID or other kinds of urgent matters where you've had to bring people together quickly. Well, what would you do? How would you do it? And anybody can start.
I'll just mention that, in Maine, we do have public health district coordinating councils, which include, and I think they exist in some other states as well, but they're at the sub-state level, county or multi-county areas, and they have been extremely useful. So if you don't have those already, I would consider them. So you could convene them yourselves, but in the case of Maine, at least they are put into statute. So they are convened officially by our state public health agency, one of their staff who work in the regions. But there's also usually a president or chair of the DCCs, district coordinating councils, who come from that area. And so they do a lot of the work, but they bring together healthcare, hospitals, FQHCs, for instance, other healthcare entities, as well as a number of CBOs. The CAP agencies, at least in rural areas where we live, is a major partner. of ours. The AAAs, so community action program, I don't mean to use acronyms too much, but community action programs or CAP agencies, the AAAs, the area agencies on aging, other similar type of entities are at the table. And that's been very critical for us during a couple of pandemics, H1N1, as well as COVID, as well as during times when the funding has been a challenge, where we've come together to figure out, okay, what can we do together better and stronger than we could individually.
That's great. Dora, I'm going to ask if maybe in the chat you could put a website where people could find out more about that council structure. If that's easy to do. If not, you can let us know later, and we'll send it to the people that are listening.
Thank you.
Rishi,
Oh, I was just going to mention, in that word cloud earlier, the relationships piece came up, and it's really important, just how important it is to have these relationships existing, and if you don't have them, to build them now and not to wait for the crisis to happen, right? I think a lot of us got to know each other certainly during the pandemic, but I think in anticipation or in sort of these other types, sort of reaching out and finding those relationships at a national level. We have regular close conversations with ASTHO as well as the federal agencies. I think that's a nice place where we sort of highlight upcoming issues and then find ways to reach out sort of at that level. But for each of our state associations, and even I was active in our county association, and each of those really have public health committees and public health leadership sort of for on the medical association side. And so those engagements and getting to know your local public health officers and then your state officers is such a key piece. And so I really want to emphasize sort of how important those personal relationships can be.
Yeah, if I may, I'll just add and maybe segue to answering a question that came in the chat from Marissa Levine, because I think it's germane to what we're talking about here, and that's the power of relationships, as Freddie was talking about, and the necessity of coordinating councils of governance structures that bring public health and healthcare together, as Dora, I took from your comment. I think those are essential now. They've always been essential, and especially now as we look ahead. To what extent are there tables already set? And if not, how do we strengthen and create those tables to ensure that public health entities and healthcare entities and community organizations, including those that provide services as well as those who do advocacy work, are coming to the table? We need to bolster the infrastructure. I think that and strengthen the infrastructure of convening, of coordinating, that allows us to be able to build those personal relationships and also get work done. What is that work to be done? I think clearly, if we think about the threats to public insurance programs, Medicaid, Medicare, and the Affordable Care Act, based on proposed policies, with the CBO, for example, estimating that if the ACA enhanced subsidies are meant to expire, up to 4 million people may lose insurance. If there are potential cuts to Medicaid, should there be tax cuts imposed, and there's an effort by the new administration and Congress to look at ways to offset those costs. Medicaid may be on the chopping block, affecting millions more. As we think about these real implications from a public health and healthcare perspective, I think we have to look at the impact of public insurance programs, again, Medicaid, Medicare, and ACA. Public health as well, CDC, NIH, and everything. I think we're seeing now, I think, real concern and anxiety among a lot of seasoned professionals in the public health community about what this might mean for being able to not just advance public health, but to protect public health. And then lastly, the public goods, meaning food, housing, transportation, the social determinants work. I think there's concerns there from a health equity and public health and healthcare perspective. What happens, for example, if there are mass deportations? What does it mean for institutions? Should hospitals participate in being sites for these things? Should physician practices? These are difficult questions, but ones that we have to at least name clearly and objectively, so that we can have these conversations. And if those conversations can be had at those tables, where the trust and relationships, solidarity, and the governance structure allows us to be able to navigate these, I think we'll be able to better respond, not just to potential impacts on health and health equity, but also to find opportunities for progress. And this is an important point I just want to stress, because I think there's certainly a lot of understandable concern among people we're talking with, but there's also some opportunities within this. If we think about, I think what is increasingly a bipartisan interest in affordability, right, in making sure that healthcare is affordable and that life in general is more affordable for Americans, there are some opportunities to come together with healthcare and public health to think about how to make the essential capabilities for health affordable. And how do we then align around that to advance a common agenda that can promote health, but also do so in a way that makes health just more accessible and affordable for Americans. There are possibilities and opportunities at the state and federal level, I think, to be able to move forward, not just beyond defense.
I was, I'm so glad you said that, Rishi. I was going to say something similar that, I mean, I've been in public health for, oh my gosh, I don't know, 30. You, John, I think you and I go back about 30 years, right? So
We do.
anyway, so we've been through a few changes in terms of administrations, both at the state level and the federal level. And with every change, you try to find what their priorities are. No matter what the change is, there's always a change in priorities, and there's always common ground. So I think that's what our goal is now. And I would say too, I would advise that people use November 6th as a clean slate, because what is said during campaigns, no matter who's running, probably more so now with the very divided kind of divided country, there's probably a lot more rhetoric that happens during the campaign, but that always happens when people are running. There's always promises and things made, statements made. So but as of November 6th, I pay attention to what is being said after the election is over, and try to figure out, okay, what are their priorities and how do they align with ours? We've already heard chronic disease as maybe a major priority. We've also heard, as Rishi said, cost savings. So we were kind of working on cost savings anyway and trying to figure out how do we show what the ROI is in terms of deferred costs or not deferred, but costs that are savings, as well as cost reductions of our programs. So we already have that data for things. So we thought it was just, we're in an economic context that's uncertain anyway, so why not do that? But I think even more so now, the administration has already mentioned that cost savings and health chronic disease improvement are two priority areas.
And I'll add to that, there's a lot of interest in prevention as an area which is really bread and butter, not just for public health, but also for clinical work too. And I think that there's a lot of opportunity there. And then as Dora knows well, rural health issues, access to care for all of us. We all know it's hard to get into care right now. It's hard to find a regular doctor or other provider, and also especially for some of our rural and underserved communities. And so those are bipartisan issues, and also issues that have really resonated with the incoming administration. And so community health centers and funding for those health centers in those areas, I think, are really good opportunities.
John, can I add to that?
Oh, please go ahead.
Sorry, just to also, in the public health kind of spirit as well, thinking about the healthcare drivers as well as the social and economic drivers as well, just to build on what Dora and Freddie were saying. There's it's adjacent to the affordability, but there's also things that we saw in the election results that may have been missed in some of the news and the review, like the fact that 3 states, notably red states, passed paid sick leave laws. Is important to note, and it has profound implications for public health, right, and for the ability to make sure that essential capabilities for health exist for Americans as well. So there are, from a social and economic policy perspective, and not just a public health and healthcare perspective, I think real opportunities to find areas and opportunities to be able to build and advance efforts that have direct and sometimes even indirect implications for health and health equity.
I think you all have begun to answer questions that we're getting in the chat. Dr. Levine had asked a question particularly about the likely or anticipated changes in with the new administration coming in. I guess I hear all of you saying, don't wait. Take advantage of forums that already exist where you can work across sectors and begin to have the discussions at as early a possible date, even before specific proposals have been put on the table. And so I think that's a helpful response to her question. And just in the spirit of the fact that we're getting really good questions from the audience, let me ask you then another one. This one comes from Dr. Zink. And what she's saying is that each of you work with healthcare providers. You work in the healthcare sector with partnerships in public health. And what she relays is that sometimes when she's working with other providers in the healthcare system, they're not always clear on how do you bring public health people to the table? How do you determine who's the right person, who's the right organization, in order to make sure you're coordinating and planning with the right players. So how have you done that? And maybe also, do you have recommendations for how others might do as well?
Sure. Well, I guess I'm going in the same order. I'll go. And Anne, thank you so much for your service in Alaska, as well as with ASTO. Good to see you again. It's a great question. And I think in my own experience, as you write, collaborative meetings to learn about each other is a great idea. I'll be honest with you, a lot of providers don't have the time to go to a collaborative meeting and learn about each other, learn about public health. It's like, okay, just give me something to do. Physicians, and I'm a physician as well, tend to be very surgical. They want to get something done. So I would suggest, besides a meeting about learning each other, learning about each other and coordinating things, if they're okay with that. But I would suggest getting into the sandbox sooner than later, identifying a need in common and really addressing it. So COVID-19 provided us, a tragic pandemic, but it provided us also a great sandbox to get in together. So we needed vaccine clinics in a hurry. And so our providers, our physicians and nurses just did not have time to put together clinics. So that's what we did. So we're kind of, in so many ways at MaineHealth, we provide a lot of the non-regulatory functions, again, in public health in our rural areas, particularly. So we convened a lot of CBOs, community-based organizations, as well as looking across the sector to see how we could provide vaccinations. The hub where I am, we provided the standardization for those clinics. We worked very closely with our state public health agency to assure we were aligned with them. But at the local level, what was nice is the providers were able to say, yeah, I'll show up and help vaccinate. I will educate my patients, but I need some educational materials. I need somebody to put on a clinic. And that's what we did in partnership with others. And we actually we ran 10 mass vaccine clinics across our service area, and then did lots of other clinics after that. We worked with a lot of ethnic community-based organizations as well, vaccinated in schools, and more people in Maine received their vaccines, COVID vaccines, from MaineHealth that first year than any other organization. And Maine had the highest vaccination rates in the country. And we actually had higher rates amongst our racial and ethnic minorities than we did amongst our whites. So we had great success, but it really was because we were working strongly in collaboration, hand in glove, with public health at the state level, community-based organizations, schools, many others, and our healthcare sector. So our healthcare providers were very excited to be involved, but they were very clear what their role would be, educating their own patients when they saw them and helping to vaccinate. But, they wanted everything else done, and we did that for them. So it's good.
Thanks. Freddie, Rishi, want to weigh in on that as well?
Freddie, do you want to go? I have a few thoughts.
Sure, thanks. I would I'll sort of point towards organized medicine a little bit, because that is a place where sort of we have an organization. I think it's going to be higher yield than going to find your local private practice vascular surgeon and trying to talk to him about bicycle helmets like that. I don't think that's going to work. And also I'll just say, as we all know, both of us we all live in worlds that are quite fragmented, right? And so, like, find me one person who can talk about all public health, find me one person who can all. So, but I do think that if you look at like your state medical association, and then some of the local associations, they all do have public health committees that would be really excited sort of engage and start to meet with you with the public, with sort of their counterparts, if you will, on the public health side. If anything, it's a challenge to sort of figure out who's the right person to talk to on the public health side, right? I think that's a legitimate sort of question. The other thing I would talk about too, not just the sort of self-serving professional society side, but the fact is that many of our physicians who want to be involved are all working in large health systems and hospitals now too. And those hospitals and health systems, yes, of course, they've got an infectious disease sort of, sort of person, but they also have linkages, I think, to local public health in various areas. And I think that's part of what we're talking about is marrying public health and healthcare delivery, and recognizing that the healthcare delivery space is really in many communities dominated by large health systems, which sort of have that level of interest, engagement, resource, and also, most importantly, physicians who want to be involved in various public health topics. And so I think that's worth exploring.
Yeah, amen. And I just to build on what's been shared, as well as going back to like Anne's question directly for what practical solutions. I do think that the energy right now and the motivation more now than ever is for translating the relational aspirations and relationships that we have in general into concrete action practically. 4 opportunities quickly, each in 4 different categories: for investments, integration, improvement efforts, and infrastructure. For investments, there are opportunities to, for example, take the community benefits work of health systems, the community reinvestment requirements emerging in certain states, especially required by Medicaid managed care plans, and the local health jurisdictions' responsibilities by local health departments to create community health improvement plans, and concretely, practically identify what you can work on together to be able to align your improvement efforts. When it comes to, that's investments, excuse me, that's the investments. There's resources there, and that needs to be aligned. There are improvement efforts, and practically speaking, we've seen one, I'll just put one thing on the table that is one of the unsung heroes of practical public health healthcare delivery integration, especially with community organizations in the mix too, which is public health detailing. We've seen examples of how public health workers can actually physically go and sit at the table, quite literally, in a medical office, to be able to promote the adoption of public health services and messages and vaccinations, et cetera. Time and again, this ranges from everything, as we know, from reducing opioid overprescribing to improving vaccination efforts and connecting kids with asthma to appropriate care in the community. Public health workers detailing, going to the healthcare providers can both advance public health efforts while also effectuating the ability for busy healthcare practitioners to be more effective. That's an improvement idea. The other within the improvement bucket is community health workers, who are the interstitial kind of glue, the connective tissue right now that we know has been powerful, not just for healthcare use cases, but certainly for public health and, of course, community ones. To the extent that the Common Health Coalition, of course, is now rallying behind a challenge, which I believe on December 9th we're going to hear more about the ways in which public health and healthcare can come together to elevate and center community health workers. As I think we can see them as practical drivers of solutions and improvement efforts. Really quickly then on infrastructure, we saw through COVID, of course, the essential role that data sharing, technology sharing, and just shared infrastructure can play when public health and healthcare come together. So I think infrastructure, it's not sexy, but man, it's important, right, to be able to identify practical solutions. And then I think lastly, integration. I think the efforts of healthcare and social care integration, much like we saw with behavioral health integration, these efforts are running faster and hotter than ever before, and I think that's going to continue in this administration, just as it did in the first Trump administration and in the Biden administration as well. I think we're going to see continued uptake of opportunities to integrate health and social care. Public health needs to be in the center of that, of making sure that those efforts to integrate health and social care are now aligned with public health efforts. So there are practical solutions there as well for public health to be part of the screening process, part of the referral process, part of the solution sets that are available for those who have unmet social needs to be able to get connected to public health resources.
I'll go ahead, Dora. I see you want to add a point. Please do.
I just wanted to make a finer point on something Rishi said that's also been asked by Aaron or mentioned by Aaron and Krista, I think. Yeah, that there are two resources. He pointed out a number of great resources, but two that I should mention that with hospitals, there are community benefit IRS regulations that the nonprofit hospitals provide back to the community. So if you've got nonprofit hospitals in your area, you can ask to see what they're providing. And that's a lot of the funds that we fund. Our efforts are funded with our community benefits dollars. And then the second resource that Rishi mentioned, that I think is also mentioned by Aaron, is the CHNA. The IRS requires all nonprofit hospitals every 3 years to provide a community health needs assessment. That's a similar one is also required by CAP agencies, community action programs. So contacting your local hospitals, if they're nonprofit, and CAP agencies is also a place to get started, because they're required to do community health needs assessments. So, and they're required to do something with those. So two sets of resources to get started and figure out, especially the community health needs assessments done by nonprofit hospitals, they let you know what they are hearing for health issues. And that's where you can find common ground and basically a sandbox to get with them in, right? So I mentioned the COVID vaccination clinics. Well, I'm probably saying, okay, well, that's kind of said and done a little bit. So what's new? Well, that's a place to go to, is the community health needs assessments and your local nonprofit hospital to find out what is on their mind. And it's going to be on the web on their community health needs assessments.
You know, and it also strikes me that of all the things you're saying, there are a lot of things that are we wouldn't have necessarily been talking about 5 years ago. You know, the importance of community health workers, the social determinants of health being a major consideration, thinking about infrastructure, thinking about the impact of the ACA with community health needs assessment requirements. All those kinds of things, I think, do create more fertile ground for some of these partnerships than maybe the more traditional ones. You know, that said, as we're looking at these great questions that are coming in, there are some challenges here, and maybe I'd ask you each to speak for a minute or two about challenges and overcoming them. You know, one challenge that somebody mentions in that I think that's Krista Wazowski mentioned was the catchment area for health systems don't always match the public health systems. So how do you kind of work that through? Other questions that come up, Dora, you raised this one also, is if you're in a very rural area and there's just a lack of organizations or lack of clinical systems, you know, how do you overcome those barriers? So we don't have time to talk about all the barriers. Maybe I'd ask you in a little bit of a lightning round, because we're getting near the end of the hour. Maybe just mention one of those challenges in a quick way you think they might be tackled in. 1 minute each, if you don't mind. That's not asking too much.
Should we go in the same order? Do you want to lead us up?
Anyone who's ready.
I'm ready.
Go.
Okay.
Rishi.
So my 1 minute answer, let's start the clock here. I think that everything that's been mentioned has been powerful, and there's so much more. I think that obviously with the wisdom in the chat as well, the people attending, that we can do. One thing I'd elevate is story. Practical solutions include not just infrastructure integration and whatnot, but also inspiration. If we need a common story to be able to apply a common sense approach to what healthcare and public health is all about, which is, as Dave was talking about and John, you were mentioning at the top, really about a shared aim of preserving and protecting health, especially for those who are most in harm's way. Storytelling, being able to collect stories from those most impacted, getting proximate to folks is something that we can do in terms of sourcing stories, crafting stories, and telling stories, especially if those stories are shared. Storytelling is an art and a science. And I think the more we invest in, and particularly I think given some of the concerns that many share in both public health and healthcare, there's a table that we can set with practical solutions to do storytelling. And I think that'll allow us to do one bridge, which is ensuring that our institutions of public health, our institutions of healthcare, including organized medicine, are in dialogue and sometimes necessary healthy tension with movements. We will see, as we've seen in the past 5 years, not just with the pandemic, but also the role of social movements. Social movements have always been a powerful vehicle for advancing public health. We need to be able to have conversations with those who lead movements and to understand how we can be in dialogue so that there's light and heat between institutions of public health and healthcare and those who are pushing for necessarily better performance of healthcare and public health. Movements and institutions together can be part of a shared story.
Thanks.
Oh, and
Hey, Dora?
yes, I totally agree, Rishi. I think the combination is really stories with data, right? Stories that exemplify the data and the data that are, exemplified by the stories. So I completely agree. There's nothing more powerful than having both working together. And I would also say even if you're in a very rural area or in an urban area, there are going to be hospitals and usually federally qualified health centers, or FQHCs. And although the FQHCs don't have the same requirements for community benefits or conducting a community health needs assessment as the nonprofit hospitals are, but at the same time, they're in a lot of areas and serving the underserved and others too. So also a partner. We partner a great deal with our community health centers, even though we're a hospital-based system with about 200 primary care and specialty practices. But we also at the local level partner very closely with our federally qualified health centers, and particularly in our very rural areas, we find them a great partner. And I also hope that through the Common Health Coalition that we will continue to have this dialogue. I am so excited for David Tosky and Chelsea Cipriano and others, the people on the board, including the American Medical Association and others who have formed this great organization. I think the timing could not be better, particularly, not only have we needed to work together over the years, but the need is going to be more, I predict, that we're going to have much more of a need in the coming years for us to work together, and we can go much farther together. So thanks.
Great point. Freddie, any closing thoughts on this question?
Oh, just I share Dora's love of community health centers as a former HRSA person as well. And then I'll shout out sort of some of my former colleagues at University of Washington who worked really closely with our state public health to really tackle the issue during the pandemic and after around hospital capacity, emergency department overcrowding, and just a nice example of a state level sort of shared resource there between public health and the hospitals to look at these important questions of capacity and surge capacity. So thank you.
Well, we could be talking about this all day long. I think we really just touched the surface, but I think some of the key messages I think you pointed out is coordination is key, and wherever you start, you have to start right away, bringing people to the table, building on what you already have if you've got something in place. And now, I think we heard underlined a few times, now is a critical time to get the folks together at a table and talk about what's happening, what might happen, and begin to think about how to prepare. And then also, I just think we really heard from the comments that are written and your comments. There's a lot of resources that are there to help. If you're in a location where you are unsure how to go about this work, you can contact Common Health Coalition and they'll put you in touch, I think, with others or connect you with resources. So with the value of the coalition in mind, let me bring on now the wonderful managing director of the coalition, Chelsea Cipriano. And Chelsea, I think you're going to tell us about some of the upcoming events as well that the coalition is involved in.
Yeah, thank you, John. And thanks, everyone. I will be very brief in these remarks. I think a lot of what I was just reflecting and hearing from what everyone was sharing is excitement that everyone seems to be similarly jazzed about talking about this stuff and the path forward, and ensuring that all of these lessons that we learned during COVID and crises before and after, and not just, acute crises, but the everyday things, are not for just lessons learned, right? It's how do we mobilize these lessons into something different? And that's what we're all talking about. So join the coalition. It's free. If you run a healthcare or public health organization or a part of one and your organization wants to join, I dropped that link in the chat. Help us be part of this mobilizing lessons across the country for a different tomorrow in the health space. And then we have our annual challenge, Common Health Challenge, as Rishi mentioned. Thank you so much for that lead up to this. please join us on December 9th. We'll be announcing the inaugural Common Health Challenge, which we're really, really excited about. We're focusing on community health workers as a catalyst for a reimagined health system. And then throughout the year, we have webinars, we have case studies coming out. We have a bunch already on our website. If you are interested in us featuring the work of your organization, because it fits really nicely into all of these themes that we've been talking about in case study, future webinar, any of our materials, let me know. We are here to be a megaphone for this work on the ground and for all of you. So these are some QR codes for staying connected. Really looking forward to hearing from those of you who I haven't yet. And thank you to our members who are on. Really thrilled to see you all today.
Thank you, Chelsea. Thanks to all of you who've joined. Please join me in wishing a happy birthday to the coalition. What it's accomplished in 1 year is amazing. We can only imagine how much more it will accomplish in the coming years. And also join me in thanking this terrific panel of incredibly smart and talented people. As Chelsea said, there's much more to come. So hope we whet your appetite, and thank you for your contributions. And we'll say goodbye. Take care.